Thank you, Brian. You mentioned 114. I was actually involved with that. I was chair of the Pharma Outcomes Committee, and we wrote with FDA the regulations for that bill. Because the bill was passed, but there were no regulations, and FDA wasn't writing them. So we formed a committee, a joint committee actually, and worked and wrote those regulations. But you're right, it just sat there for many years because there was no reason. No one was pushing outcomes as much as they are today. Okay, our third speaker is Stephen Udvarhelyi. He's going to give the payer perspective. He's Executive President of Health Services and Chief Strategy Officer of Independence Blue Cross. He's responsible for clinical services, medical management, pharmacy management, quality management, and wellness, and he has a lot of responsibility. Contracting, provider networks, and informatics, author of How to Cross the Potomac Without Falling In, and I've got that on my list to read. Formerly Executive VP of Health Sciences, responsible for most operating areas of IBC. Stephen.
Thanks.
And don't forget the questions on the cards.
So the 50-point bonus question in your continuing education is to spell my name at the end without the... So I have no disclosures that I have to give, I think, at least for this. I wanted to go through a few things. To start, a lot of folks that I talk to actually don't know much about the Blues. I won't go through this in detail, but just, the organization that I'm part of is actually part of a national system. We're actually all independent companies. There are now only 37 of them left. There were, several years ago, over 120. That gives you a sense of the consolidation that's going on in our industry. The history, which I think is relevant, is for those of you who don't know, Blue Cross organizations were started to pay hospital bills. Blue Shield organizations were started to pay physician bills. They were separate organizations. They didn't merge until 1982. Pennsylvania is sort of an outlier in that we have 4 Blue plans in the state. Most states only have 1. In some states, they're now one organization over multiple states. And collectively, the Blues represent about 100 million people. I would just tell you that this number 37 is going to be substantially lower as we go future. I can't tell you what the number is going to be, but there is going to be continuing consolidation. We've been in business for 75 years. We cover or take care of about 2.5 million people in this geography, but about 7 million members nationwide. Most people don't know that even though we're a 5-county Blue plan here, we actually operate through our subsidiaries in about 15 states and employ about 7,000 employees. Most of that geographical spread is actually in the Medicaid space through our Medicaid subsidiary. And although our parent organization is a not-for-profit, most of our subsidiaries are for-profit. And just to dispel sort of what not-for-profit means, over a 5-year period, Independence Blue Cross pays about $1 billion in non-payroll taxes. So that's sort of the irony of being a not-for-profit in Pennsylvania these days. Our mission, vision, and value proposition, I would focus here really on the mission of our company. We exist to enhance the health and wellness of the people and communities we serve. So that's why we're in business. We don't have, we're proud to not have necessarily a need to return value to shareholders. That's not a bad thing, but we're really to serve the people and communities that we're in. And we really want to exceed our customers' expectations through innovative solutions. So think of that mission and then think about sort of why comparative effectiveness is important for us. I'm going to give you the definitions from the Institute of Medicine. I sat on the committee that was responsible for figuring out how to spend the $400 million that was given. It was an eye-opening exercise, I will tell you. It was hard to keep the list to 100 initial priorities because of the amount of things we don't know what works well. But the IOM definition is the generation and synthesis of evidence that compares the benefits and harms of alternative methods to prevent, diagnose, treat, or monitor a clinical condition or to improve the delivery of care. Now, I would just say, what is not on this definition? Nothing about cost, right? There was a heated debate at IOM and when we went out about whether or not comparative effectiveness should include anything to do with cost effectiveness. And for a variety of reasons, and I would say probably some political and for valid reasons, the cost issue was taken off the table. And the IOM purpose was, as is said by other speakers, it's really to help make decisions. In this case, it's to help consumers, clinicians, purchasers, and policymakers make informed decisions that will improve healthcare at both the individual and the population level. But again, what's not here is anything about cost. So I would say, as a payer, we do feel that we are the disproportionate voice for caring about the cost of healthcare in addition to what helps heal and make people well. And I'm going to give you a few facts about why I think as the healthcare landscape is evolving, we're going to see more concern about cost at the individual patient consumer level. And that's because there's a value problem in healthcare. So the value problem is cost, right, and quality. And cost is escalating. It's really becoming unsustainable. And, you know, Uwe Reinhardt at Princeton debates that. He says, you know, we don't really need to worry about how high the GDP goes. It can go as high as we want. But, you know, Philadelphia, where we live and work, is a very high-cost market. And the quality problems in the U.S. are, you know, rampant. So we have variation in practice. There really is limited scope of what's evidence and evidence-based medicine. Anybody here have any idea gaps in quality to fail to implement works? How long does it take for when we know something works? How long does it take for that to disseminate into active clinical practice, on average?
17.
Yeah, right. So by almost 15 years. And that's the test of by the time we know till it becomes, this is standard practice in a textbook. So think about that 15 years, okay? Here's sort of another scary thought. When I was in medical school, you'd be convicted of malpractice of putting a patient with congestive heart failure on a beta blocker. Today, you'll be convicted of malpractice if you don't put a patient with congestive heart failure on a beta blocker. Think about that lag. So here's the cost issue, right? So the blue bars, this is a little data. This is up through 2009. This is the percent of GDP that goes to healthcare. It was 18%, headed up to probably 20%. And the bottom part is a public perception of what's important to them about healthcare. So in 1999, the public was more concerned about AIDS, cancer, and other things than healthcare costs or insurance costs. In 2009, 10 years later, access to healthcare and healthcare costs outstripped their concerns about things like the avian flu, cancer, or obesity. 10-year period. 69% of Americans worry that healthcare costs will go up faster than their income, and 60% have stated that they have not gone to get treatment because of the cost of healthcare. So if we do not think that the cost of healthcare is a problem in delivering quality in this country, I think we have our heads in the sand. So cost is an issue that collectively we have to deal with if we're going to improve the quality of healthcare. On the quality side, if as physicians, knowing what works is not enough. If you look at this, and I actually had a conversation with a cardiologist. I'm going out next week to give a talk to the largest cardiology group. It's in this town. It's actually the largest cardiology group in the country. And I shared this data with them. They don't actually know this. But even when we know what works, and this is data from Beth McGlynn when she was at RAND, 55% of the time, patients do not get care in accordance with what we know works, even though there's this 15-year lag as well. 45% of the time they do, and it ranges from something like giving anticoagulation for patients with atrial fibrillation, which everybody should get. We get that right 25% of the time. And we're a little bit better for coronary heart disease, but you see things like screening, simple screening treatments for colorectal cancer about half the time. So we're paying a lot of money but not getting it. This talks about some of the other quality problems. This is from an old friend of mine, Chuck Buck, when he was at General Electric. General Electric makes the aircraft engines, right? You want those to be high quality. So GE manufacturing is well past Six Sigma. Okay, that's the best in class U.S. industry down there. Anesthesiologists are pretty good in healthcare. Look where hospital-acquired infections, outpatient antibiotics for colds, overall healthcare in the United States up there, and then look at airline baggage handling down there, Philadelphia Airport. The baggage handlers at Philadelphia Airport get it right better than we do for most of this. Okay? So if you're wondering about the disconnect between quality and cost, I hope these are some sobering facts. And as a country, we really struggle to manage population-based health. If you look again over time periods, look at the rate of rise of childhood obesity, prevalence of diabetes, prevalence of heart disease, and there we are in the United States down here at the bottom of a long list of countries in terms of life expectancy at birth, despite the fact that we spend more money per capita than any of those countries on health care. So a real value problem. So for us, even though the IOM wasn't able to tackle the cost effectiveness issue, CER, in addition to finding out what is the right way to treat the patient and help them, has to help us solve this value problem that we have in healthcare by getting at the issue of not just what works, but what is the most cost-effective solution. So for us, when we make decisions, people say, how does a company like Blue Cross make decisions of what we're going to cover and how we're going to cover it? So it's pretty simple. The first thing is if it needs to have federal approval, you got to have federal approval. The second is that we need to see evidence that permits conclusions that the technology has a beneficial effect on health outcomes. I would say the biggest place where we get in debates on this is not so much in pharmaceuticals. The FDA actually, relative to other things, does a pretty good job, but devices are terrible. All you have to do is put one out that looks like it's not going to hurt anybody, and we're in the unfortunate position of having to ask for a lot of evidence whether it works. The technology needs to improve net health outcomes. And that means not just for a good example of that is a drug may decrease cardiac outcomes but increase overall death rates. The technology must be beneficial as established alternatives. And this is where we look at cost effectiveness, right here under 4. So that if we have established alternatives, we do look at whether or not we can get equal benefit at a significantly lower cost. And if you don't think that the average person on the street cares about this, years ago we decided under our pharmacy benefit program to introduce a $0 copay for all generic drugs. We then surveyed our members and physicians to see what happened after we did this. Patients went in droves to their doctors and said, could you prescribe a generic drug for me? Because for them, the difference for paying out of pocket of even as little as $10 a month for their drug was enough of a motivator to say to the physician, can't you prescribe something for me? And we saw in areas like antibiotic prescriptions for upper respiratory tract infections, a big shift away from expensive medications down to generic drugs. And then lastly, improvement must be attainable outside the investigative settings. So comparative effectiveness research will factor in, as you can see, to a lot of these different areas. But it's not really the coverage decision where I think CER is going to have an impact. If you look at what's happening in the health insurance industry, and it's going to accelerate under healthcare reform, think about under healthcare reform the whole issue of what is the essential benefits package? What does everybody need to cover under whether it's the bronze, the silver, or the gold and platinum benefits that are going to be on the exchanges? Evidence-based benefit design is going to rely on comparative effectiveness to decide what is that base level of coverage that everybody needs to get. Second area you're going to see is what's called reference-based benefits. Anybody know what reference-based benefits are, right? It basically says we're going to fix the benefit at a certain level, and that's where cost effectiveness comes in. So, years ago when TPA came out and streptokinase was out, CMS solved this by setting the price for both somewhere between the middle and said to the hospitals, you go figure it out. We're going to overpay you for one and underpay you for the other, and you figure out the mix. But I don't think that's what's going to happen here, but I think you will see reference-based benefits will come out to the most cost-effective alternative. And then the cost burden for buying up will be left on either the risk-bearing entity, in which case it could be the provider in a risk-based contract with the payer, or it's going to be cost-sharing on the patient. Okay? You're going to see, I think, a rapid move to defined contribution health benefit plans. So we've seen in the pension market today, only about 5 to 10% of companies actually offer a defined benefit pension. Everybody else offers a defined contribution 401k. This is where health insurance is going to go. So employers are basically going to say, you, the employee, you get $10,000 a year, go out, buy health insurance, good luck, whatever you want. That's going to cap the willingness they have to buy expensive coverage, and they're going to get much more engaged now in wanting to know what is the cost of the service that I'm getting, and that's actually going to make it into the exam room with a physician. Tell me, doctor, what the cost is of this treatment that you're recommending for me, and is there a different alternative, because that's affecting the level of coverage that I can have. And for those of you that are not sort of economists, understand that today health insurance is a wage trade-off in this country, which is why when we have union problems and union negotiations, it always comes down to health benefits versus wages. And that's really what the defined contribution benefits are going to plan. It's going to be a trade-off between wages and how much money they're going to give to the employee to buy health insurance. High deductible health plans are just going to put more of the front-end coverage on individuals, going to make them more cost-sensitive again. And then what we see is a move to shared savings or shared risk provider contracts between us and providers. So we're going to get out of, Brian said, the prior authorization. We're going to get out of that business. We're not going to be doing the prior authorization anymore. What we're basically going to say, and this is prevalent today in California, I know a physician that runs the largest medical group in Southern California, Healthcare Partners, Bob Margolis. They just sold to DaVita, that some of you may know. The way that it works in California is that medical group basically takes a full risk payment from the insurance company to cover the cost of care, and they make the decision of how to allocate that 85 cents on the dollar that's going to patient care. And it's the primary care physicians in that group who are making the decisions about what treatments to use, where to refer. They are going to now become the users of comparative effectiveness and cost effectiveness research to figure out how do they stay solvent in that risk contract as that financial risk goes down. Medical homes will be a part of that, and accountable care relationships, if not accountable care organizations. So you're going to see the decision making that's historically been what gets covered is going to change to what do I prescribe or what do I order. And it's going to be done by the ordering physician now in a risk relationship, not a coverage decision by the payer. So what we see, again, Brian mentioned this, we do see a move from fee-for-service to pay-for-value. The value will create a demand for this comparative effectiveness research. We're going to strengthen the primary care infrastructure through medical homes and other things. We are going to see vertical clinical integration, maybe not mergers, but you're going to see vertical integration of the delivery system because the hospital business, I think, is going to slowly shrink and go away and be replaced by more ambulatory care, and they're going to get into that business. And it's going to come through a combination of incentives, but also feedback and transparency. Today, as our member, if you're a member and you're going to go get care, you can go onto our website and you can get cost information for about 250 different services. So just think about if you're an employee who's making $30,000 a year in a high deductible plan, and you're now trying to figure out how you're going to get those services, and you go on the website and you have the option to get an MRI for $1,000 or to get an MRI for $500, which one are you going to do? Well, same thing. If you have a conversation if you can get a drug prescribed for $150 a month or $15 a month, and you're out of pocket, which one are you going to do? So this transparency is going to change individuals' behavior, and it's going to change clinicians' ordering behavior. So we see the future state, and this is just giving an idea, is that medical homes will serve as the predominant model for primary care. They will also be the foundation for the accountable care organizations' relationships, that the medical homes and the accountable care organizations will take over some of what we've historically done in disease case management, care coordination. Integrated provider entities will begin to assume both clinical risk and financial risk, and they're going to need tools and information to manage that risk, and that, again, will create demand for CER, not so much for coverage decisions, but now for clinical ordering decisions. You're going to see information exchanges will permit us to exchange information in a way that wasn't available before. And transparency is going to really change the decision making that's out there. And I think it's going to, we're going to have, unfortunately, better information on cost early on than we do on quality. But hopefully that imbalance will push the demand for outcome data moving forward. Although I will just say, unfortunately, we're always going to have better data on cost than we will on quality, because the quality outcomes are limited to specific conditions. And then we're going to see continued migration of the traditional health benefit plans to more of a consumer-oriented fashion, these defined contributions. But health insurance, and this is just one person's opinion, health insurance and healthcare is going to become an individual market. Today it is a group market. And when it fully transitions to an individual market, I don't think we collectively understand the impact that that individual decision making by the consumer who's now making those cost-quality trade-offs is going to have on the decision. And the demand we have today for comparative effectiveness research, I think, is going to accelerate rapidly, and we're going to see non-traditional entrants into this space, because you're going to see the kinds of computer learning algorithms that Google and other people use enter this space rapidly because they're going to have access to the information. And so I think we are in for a wild ride. But that's just one person's perspective on sort of the changes that are going to happen and how the demand's going to change. So thank you.